And today, actually, we are starting the sixth series of webinar, long case discussion. And today's speaker is Dr. Anurada Jayathilake, and he's the senior lecturer and the consultant surgeon and attached to the Rajarata Medical Faculty. He is the head of the Department of the Surgery, and not only that, he is a trainer for the National Trauma Management course and as well as initial trauma management care for the nurses. And he will be talking about the chronic pancreatitis today. And he is the best person to talk about because he is very interested in hepatopancreatic and biliary surgery. Dear sir, over to you.
Thank you very much, sir, for your kind introduction. Okay, I will just let you know the today's plan. So I think one of you ready for the first I will do the interactive session and the history taking. It need to be done by one of you. I will be the patient, and then I will ask about the possible examination findings and then the discussion. So usually we do have 10 minutes for the history and just 5 minutes for the examination, and we'll give you 1 minute to prepare the summary, and then discussion another 10 minutes discussion. So that's how it goes in the exam. So we will first, I think one of you is ready to get the history from me. You can get the history from me, right? Okay. Who is going to get the history?
So me, I'm the one gonna take the history, sir.
Okay, Malika, right?
No, sir, I'm Malisha.
Sorry, Malisha.
Malisha.
Malisha,
Yes,
right?
sir.
Okay. Yes, Malisha. Can you switch on your video? Is that okay?
Okay, sir. Okay.
Right.
Am I audible, sir?
Yes, I can hear you.
Can I start?
Yes. Okay.
මහත්මයා මම අවසාන වසර වෛද්‍ය ශිෂ්‍යාවක්. මට ඔබතුමාගේ නම දැනගන්න පුළුවන්ද?
මම ගාමිණී.
වයස කීයද ඔබතුමාගේ?
වයස 48යි.
38යි. ඔබතුමාගේ ගෙවල් කොහෙද?
කැකිරාවේ. ડોක්ටර්.
ඔබතුමා රස්සාවක් කරනවද?
මම ડોක්ටර් මේ බස් එකක තමයි වැඩ කරන්නේ. දැන් නම් වැඩට යන්න බෑ.
රස්සාවට යන එක නවත්තලාද තියෙන්නේ?
ඉතින් පුළුවන් වුණාම යනවා. ඉතින් අමාරු පිට යන්න අමාරුයිනේ ડોක්ටර්.
මහත්මයා ඔබතුමා කසාද බැඳලාද?
ඔව්.
මේ සැරේ එන්න හේතුව මොකක්ද?
මේ බඩේ කැක්කුම වැඩි වෙලා තමයි.
බඩේ කැක්කුම කියන්නේ කොයි හරියද කැක්කුම තියෙන්නේ?
බඩේ මේ උඩ හරිය ડોක්ටර්.
උඩ හරිය කැක්කුම තියෙන කොච්චර කලින්ද දැන්?
ඕ ડોක්ටර් ඒක නම් දැන් අවුරුදු 3-4ක් වෙනවා ડોක්ටර්.
බඩේ උඩ හරිය නේද මහත්මයා කැක්කුම තියෙනවා කිව්වේ. දැන් මේ අවුරුදු 3-4කට කලින් කැක්කුම එනකොට කොහොමද ආවේ? එකපාරද ආවේ නැත්නම් ටික ටිකද ආවේ?
මුලින්ම හැදෙද්දී ડોක්ටර් දැන් අවුරුදු 4කට 7කට විතර කලින් උනේ එක සැරේම කැක්කුමක් ආවා මේ ඇවිල්ලා ටිකක් ඉවස ගන්න බැරි තද කැක්කුමක් ආවේ. ඊට පස්සේ මම ඉතින් ගෙදර ඉන්න බෑ. ඊට පස්සේ ළඟ ඉස්පිරිතාලෙට ගියා. ඉස්පිරිතාලෙන් අනුරාධපුර හොස්පිටල් එකට මම ට්‍රාන්ස්ෆර් ලැබුවා.
එතකොට මහත්මයා මේ කාලේ අවුරුදු 3-4 ඇතුළත ඔබතුමා කී සැරයක් විතර මේ කැක්කුම නිසා හොස්පිටල් ඇඩ්මිට් වෙලා තියෙනවද?
ડોක්ටර් ගණන් කරගන්න බැරි ගන්නට ඇවිල්ලා තියෙනවා. මට මේවා කියන්න මතක නැහැ. ගොඩාක් සැරයක් ඇවිල්ලා තියෙනවා.
එතකොට මහත්මයා මේ දැන් මේ කැක්කුම නිසා මහත්මයා මේ කැක්කුම මේ දැන් අපි කැක්කුම 0 ඉඳන් 10 වෙනකන් කිව්වොත් ඔබතුමාගේ තියෙන කැක්කුමට ඔබතුමාට දෙන්න පුළුවන් අංක කීයද?
දැන් නම් ડોක්ටර් 10යි.
10ම දෙන්න පුළුවන්.
මට ඉන්න බෑ. ගොඩාක් අමාරුයි. දැන් ටිකක් විතර අඩු වෙලා තියෙනවා මේ ආවට බෙහෙතක් විතර පස්සේ. ඒත් හරියටම ආන්සර් කරන්නේ නැහැ ડોක්ටර්.
කැක්කුම මහත්තයා පිටිපස්සට කොන්ද පැත්තට යනවා වගේ දැනෙනවද?
කොන්දත් වේදෙනවා ડોක්ටර්. ගිහිල්ලා පිටිපස්සට.
එතකොට කෑම කෑවහම වැඩි වගේ තියනවද?
කටේ තියන්න බෑ. කන්න බෑ. කැක්කුම වැඩි
වුණාම තෙල් වගේ කෑම වලට නේද ගොඩක්ම කැක්කුම එන්නේ?
කැක්කුම වැඩි වුණාම මොකුත්ම කන්න බෑ ડોක්ටර්. සාමාන්‍යයෙන් මම තෙල් කෑම කන්නෙම නෑ මට කන්න එපා කියලා තියෙනවා.
එතකොට කැක්කුම වැඩි වුණාම ඔබතුමා මොකද කරන්නේ? ඉඳගෙන ඉන්නවද? බඩ මේ ඉස්සරහට නැමිලා හිටියාම කැක්කුම අඩු වෙනවද?
ටිකක් විතර අඩු වෙනවා ඒනට ඉතින් අඩු වෙන්නේ නැහැ එහෙමටම. ටිකක් විතර අඩු වෙනවා. දැන් ඉතින් ડોක්ටර් අවුරුද්දක විතර ඉඳන් හැමදාම පොඩ්ඩක් හරි කැක්කුම තියෙනවා. ඉතින් හැමදාම කැක්කුමේ ඉන්නේ ඉතින් සමහර දවස්වල ගොඩාක් වැඩි වෙනවා. ඉතින් වැඩි වෙන වෙලාවල් වලට මම ඉස්පිරිතාලේ නතර වෙනවා. ඒක තමයි යන්නේ ඉතින්.
මහත්මයා මීට අමතරව ඔබතුමාට ටොයිලට් යනකොට වගේ නිකන් තෙල් වගේ පා වෙනවා වගේ නිකන් අමුතු ගඳක් තියෙනවා වගේ එහෙම තියනවද?
ටොයිලට් යද්දී ડોක්ටර් තෙල් වගේ යනවා.
තෙල් වගේ යනවා.
අවුරුදු 2ක විතර ඉඳන් එහෙම යනවා අර මේ බෙහෙත් ජාතියක් දීලා තියෙනවා. ඒක ගත්තාම නම් ටිකක් විතර අඩු වෙනවා. ඉතින් ඒවා හැමදාම ડોක්ටර් ක්ලිනික් වල නෑනේ ඉතින්. ඊන මොන දවස් වලට ටිකක් හොඳයි. එහෙම නැත්නම් ඉතින් යනවා.
මහත්තයා මීට අමතරව ඔබතුමාට මේ කාලය ඇතුළතදී කන්න අපිරියාවක් වගේ දැන් මේ ඔබතුමා කෑම කන්නේ නැත්තේ කනකොට තියෙන මේ වේදනාව වැඩි වෙනවට තියෙන බයටද නැත්නම් කන්න අපිරියාවක් තියෙනවද?
සමහර දවස්වල ડોක්ටර් අපිරියා කැක්කුම වැඩි වුණාම අපිරියා ගැතිය එනවා. නැත්නම් ඉතින් අර ආසාව තිබුණත් කන්න විදිහක් නැහැ. කැක්කුම එනවනේ.
එතකොට ඔබතුමාගේ බර අඩු වුණාද මේ කාලය ඇතුළත?
අර නම් ටිකක් ඉස්සරට වැඩිය සෑහෙන අඩු වෙලා තියෙනවා. Sorry, I couldn't hear you. මොනවද කිව්වේ?
ඔබතුමා
Sorry, මට ඇහෙන්නේ නැහැ. Hello.
Hello. Am I audible, sir?
Yes, yes. Yeah.
ඔබතුමා බර මැන්නද මේ කාලය ඇතුළතදී?
මැන්නේ නැහැ ડોක්ටර්. බර මැන්නේ නැහැ. ඒ මට මං කෙට්ටුණා කියලා මට පේනවා.
ඔබතුමාගේ ඇස් කහ වෙලා ඇඟ කහ වෙලා ඇඟ කසනවා වගේ ගතියක් ඇවිත් තියෙනවද?
මේ සැරේ නෑ ડોක්ටර් මගේ හැබැයි කලින් නම් වෙලා තියෙනවා.
මේ සැරේ එහෙම දෙයක් උනේ නෑනේ? නෑ
මේ සැරේ නෑ.
කලින් අවස්ථාවලදී කොහොමද උනේ?
කලින් මට නිකන් අර මුත්‍රාවල පාට වගේ වෙනස් වුණා.
නිකන් තද පාටට වගේ ගියාද?
කහ වෙලා ඇඟ කසන්න ගත්තාම ඉස්පිරිතාලට ගියාම මොනවද කරායි? ඊට පස්සේ හරි ගියා. එහෙම දෙපාරක් විතර වෙලා තියෙනවා.
ඒ ආපු හැම සැරේම මහත්මයා මේ එක පාර තද විදිහට ඇඟ කහ වෙලා එහෙම ආවද නැත්නම් ටික ටික වගේද?
ඒක මට එහෙම කියන්න නම් තේරෙන්නේ නැහැ.
කමක් නැහැ. ඔබතුමාට වමනේ යනවා උගුරට එනවා ඒ වගේ අමාරුකම් තියෙනවද?
වමනේ යනවා උගුරට එනවා වගේ දැනට නෑ ડોක්ටර්. කැක්කුම වැඩි වෙන වෙලාවට පොඩ්ඩක් අමාරු ගතිය එනවා. ඊට පස්සේ
වමනේ යනවද?
එක සැරයක් දෙසරයක් වගේ යනවා. මම ලොකුවට යන්නේ නෑ.
වමනෙත් එක්ක ලේ යනවද?
ලේ නම් ගිහිල්ලා නෑ ડોක්ටර්.
මුත්‍රා කරනකොට මේ ටොයිලට් එකට යනකොට තාර කළු පාටට වගේ ගියේ එහෙම නෑ නේද?
එහෙම එක සැරයක් දෙසරයක් ගිහින් තියෙනවා ડોක්ටර්. ඒක ඉබේම හරි ගියා.
එතකොට ඔබතුමාට රැට ඇස් පේනවා අඩුයි එහෙම තියනවද? අන්දිපත් අමාරුව එහෙම නෑ නේද? ඔබතුමාට දියවැඩියාව තියනවද?
දියවැඩියාව ડોක්ටර් මේ මට මේ ළඟදී දැන් හිතලා තියෙනවා.
ළඟදි කියන්නේ මේ ළඟදි පරීක්ෂා
දැන් ළඟදී කියන්නේ අවුරුද්දක් විතර ඇති. දැන් මේ ළඟදී තමයි මට දැන් අවුරුද්දක් වගේ ඇදිලා ඉන්සියුලින් ගන්නවා ડોක්ටර්.
වලින්මද පටන් ගත්තේ?
ඔව් ඉන්සියුලින් වලින් ඔව් බෙහෙත් වලට හරිය ගියේ නැහැ.
එතකොට ඔබතුමාට මේ සීනි අඩු වෙලා කලන්ත දාලා වගේ එහෙම ස්පිරිතාලේ නවත්තලා ඉඳලා තියෙනවද?
මගේ අර සීනි එකම අඩු වෙනවා ડોක්ටර්.
හ්ම්.
ස්පිරිතාලේ නතර වුණේ නැහැ. ඒ වෙලාවට මොනවා හරි ටොපියක් වගේ ගෑවම ටිකක් හරියනවා.
හරියනවා. දැන් මහත්තයා දැන් කීප සැරයක්ම මේ ඔබතුමා ස්පිරිතාලේ නැවතිලා ඉඳලා තියෙනවනේ. ඒ අවස්ථාවවලදී ඔබතුමාට මොනවද දුන්න බෙහෙත් එතකොට මොනවද කරපු පරීක්ෂණ කියලා මතකද?
මට කැක්කුමට දෙන ටැමඩෝල් එහෙම දීලා තියෙනවා. ටැමඩෝල් තියෙනවා ඒ වගේ බෙහෙත් තියෙනවා මට. දැනට
මොන හරි පරීක්ෂණ කරාද?
පරීක්ෂණ ගොඩක් කරා ડોක්ටර්.
ස්කෑන් පරීක්ෂණ? හා.
ස්කෑන්
එතකොට බඩේ ජෙල් ගාලා කරපු පරීක්ෂණය විතරද කරේ නැත්නම් අර පෙට්ටියක් වගේ එකක් ඇතුළට දාලා පරීක්ෂණයක් කරාද?
කරා ડોක්ටර් ස්කෑන් ගොඩක් කරා.
හා ඒක කරලා ඔයාලට මොන හරි කිව්වද?
ඒ වගේ කරලා ඉතින් මගේ කියන්නේ මට තියෙන ලෙඩේ මොකද්ද මාසෙද මොකද්ද මන් දන්නේ මට ඒක හරියට මතක නැහැ. මේ ඒකේ මොකක් එකක් කියලා තමයි කිව්වේ ડોක්ටර්. ඒක හොද කරන්න බෑ කියලා කිව්වා.
අමතරව ඔබතුමාට කලින් ඉඳන් තියෙන අසනීප තිබ්බද?
නෑ ડોක්ටර්. ඒකත් එක තමයි ඔක්කොම අසනීප ආවේ.
Am I audible sir?
yes yes. එහෙනම් දැන් එනවා.
කොලෙස්ටරෝල් එහෙම නෑ කිව්වා නේද? පිත්තාශය ගල් එහෙම තිබිලත් නෑ කිව්වනේ. අර ස්කෑන් කරපු වෙලාවේ ඒ වගේ දෙයක් අහුනේ නෑනේ.
මුලින් මෙයා කරද්දී පිත්තාශය අයින් කරා.
පිත්තාශය අයින් කරා.
ඔව්. ඒ මුලින්ම කිව්වේ මේක පිත්තාශය අමාරු හින්දා එන්නේ නැති කියලා ගල් හින්දා. අයින් කරත් දිගටම එනවා කැක්කුම.
අයින් කරත් කැක්කුම එනවා නේද දිගටම?
ඔව්.
ඊට අමතරව කලින් ඉඳන් තියෙන අසනීප මොකුත් තියනවද?
ඊට කලින් ඉඳන් තියෙන අසනීප නෑ.
නෑ නේද? පිත්තාශය අයින් කරේ කොයි කාලෙද?
ඒක දැන් අවුරුදු 2කමාරක් නෑ 3ක් විතර වෙනවා ඒක. මට මුලින්ම හැදුනාට පස්සේ අයින් කරා ડોක්ටර්.
මුලින්ම හැදුන වෙලාවේ තමයි අයින් කරේ.
අයින් කරා.
ඊට පස්සේ වෙන ඔපරේෂන් මුකුත් කරේ නෑ කිව්වනේ.
ඔව්. පිත්තාශය අයින් කරපු එක කරා. එච්චරයි තමයි කරේ. තව මොකද්ද ඔපරේෂන් එකක් ඔයා කැමති නම් කරන්න පුළුවන් කිව්වා මම ඒකට කැමති වුණේ නැහැ ડોක්ටර්. මොකද්ද දන්නේ?
මොකද්ද මේ ඔපරේෂන් එක?
එහෙම කිව්වා. එහෙම තියනවා කිව්වා කරන්න.
ඇයි කැමති වුණේ නැද්ද?
ඒක මොනාරි වුණොත් ડોක්ටර් කියලා මට බය හිතුණා. හැබැයි ඉතින් දැන් නම් කමක් නැහැ කියලා හිතුණා මේ හැදෙන කැක්කුම හැටියට.
එතකොට ඔබතුමා දැන් වේදනානාශක බොනවා කිව්වා නේද?
ඔව්.
හැමදාම බොනවද නැත්නම්
අන්තිම කාලේ ડોක්ටර්
විතරද නැත්නම් හැමදාම බොනවද?
අන්තිම කාලේ හැමදාම වගේ බිව්වා. ඒ බොද්දිත් තමයි කැක්කුම වැඩි වුනේ.
ඒ ඔබතුමාට ඒක
අනේ ඇහුන්නේ නැහැ. sorry.
අන්නවා කිව්වනේ. කනෙක්ෂන් ඉෂුස්. මගේ පවුලෙන් එන අසනීප මොකද තියනවද?
පවුලෙන් එන මොකුත් නැහැ.
අග්නාශය දිම්මිලා එහෙම අසනීප තිබ්බද? කැන්සර් තත්ත්ව වගේ මොකුත් තිබ්බද? එහෙම නැහැ. ඔබතුමා බැඳලානේ නේද?
ඔව්.
දරුවෝ ඉන්නවද?
දරුවෝ 3 දෙනෙක් ඉන්නවා.
එයාලා මොකද කරන්නේ?
ඉස්කෝලේ යනවා.
ඔබතුමා වයස කීයද? 48යි නේ. ඔබතුමා මේ ඇල්කොහොල් දුම් වැටි පාවිච්චි කරලා තියෙනවද කලින්?
දැන් නම් ගන්නේ නැහැ ડોක්ටර්. දැන් නම් ගන්නේ නැහැ.
කලින් ගත්තද?
කලින් ගත්තා. හොඳට
කොච්චර කාලයක් විතර ගත්තද?
අපෝ තරුණ කාලේ ඉඳන් මේ කාලේ වෙනකම්ම කියන්නේ ලෙඩේ හැදෙනකම්ම ගත්තා. ඊට පස්සේ ડોක්ටර්ස්ලා කිව්වා නවත්තන්න කියලා. ඊට පස්සේ බිව්වේ නැහැ.
අවුරුදු සෑහෙන කාලයක් බිව්වනේ.
ඔව්. අවුරුදු
එතකොට අරක්කු ඇල්කොහොල් ගන්නකොට ඔබතුමා මොනවද සීල් අරක්කුද ගන්න නැත්නම් ගමේවද?
මේ කියලා එක නැහැ ડોක්ටර්. අහුවෙන එක ගන්නවා.
හැමදාම බොනවද නැත්නම් මේ සතියකට කීප සැරයක් වගේ එහෙමද?
සතියට 4-5 සැරයක් වෙනවා ડોක්ටර් කොහොමද? බස් එකේ වැඩ කරන්නේ මහන්සි ආවම.
එතකොට කොහොමද බොන්නේ? බොනකොට භාගයක් කාලක් එහෙම කොහොමද බොන්නේ?
කාල භාගයක් අතර දෙනවා.
හැමදාම දුම් වැටි පාවිච්චි කරනවද?
ඒ අරක්කු බොන වෙලාවට බොනවා.
සිගරට්ද බොන්නේ බීඩිද බොන්නේ?
සිගරට්.
දවසට කීයක් විතර බොනවද?
එහෙම නෑ ડોක්ටර්. ඒ කියන්නේ අමාරු ඒ කියන්නේ මෙයා ඒ කියන්නේ බොන වෙලාවට බොනවා ඉතින්. 5-6ද කියලා නෑ ඉතින්. තියෙන ප්‍රමාණයක් පිට වෙනවා ඒක.
එතකොට ඔබතුමා මේ අර කෑම කනකොට කැක්කුමයි කියවනේ. ඒ කැක්කුම නිසා මේ ඔබතුමාට මේ ඉස්පිරිතාලෙන් අර බෙහෙතක් දුන්නේ නැද්ද? මේ අග්නාශයක අර යුෂයක් වගේ තියෙන එන්සයිම් එකක්.
ඒ කෑම දිරවන්න කියලා බෙහෙතක් දුන්නා
ඔව්
ડોක්ටර්.
කෑම දිරවන්න.
මම හැමදාම නෑනේ. ඒක ඉස්පිරිතාලේ හැමදාම නෑ. ඉතින් තියෙන දවස්වල නැති දවස්වල
ඒක ගත්තාම අඩු වෙනවා නේද?
ඔය එක ගත්තාම අඩු වෙනවා. So you done with your history?
Yes,
I think
sir.
do you have anything to ask? I think because of the interruption, I can give some more minutes if you want.
Regarding the past surgical history, I want to ask whether am I audible, sir?
Yes, yes.
Regarding the past surgical history, sir, I want to ask whether the patient had any previous surgeries like ERCP. And
Yes.
I want to ask about whether the patient is having any allergies to food, drugs, or plasters.
Right. No allergies. Right. Okay. Right. So what do you want to examine?
On the examination, sir, I would like to start from the general examination.
So what are the specific thing you need to examine? You need to check.
The general examination. On the general examination, I would like to measure the BMI, sir, because as this is a emaciation. Because of that, Am I audible, sir?
Yes, yes. No. Go ahead.
Sorry,
Monali, give me.
sir. I think I
Right out.
next wait and
Sorry, give me a second, right? Sorry.
so excuse me, sir. Can I switch the camera? Am I audible, sir? Am I audible, sir?
Can you hear me now?
Am I audible, sir?
Yes, I can hear you.
So sorry, sir. I switched off the camera because of the connection
Okay,
issue.
that's all right. Right. Okay.
For the examination, I would like to start from the general examination, sir.
Okay.
On the general examination, I would like to check whether the patient is emaciated or not, and I would like to check the height and weight and measure the BMI of the patient.
Okay.
And on the face, I would like to examine whether the patient is pale or not.
Okay.
Because as this is a chronic inflammation, that can lead to anemia.
Okay.
And I would like to examine whether the patient is icteric or not, because as in chronic pancreatitis, that can lead to obstructive features like icterus.
Okay.
And as this is a patient with chronic alcoholic, I would like to check the parotid enlargement as well. And on the oral, I would like to check whether the patient is having good oral hygiene and whether the patient is having micronutrient deficiencies like angular stomatitis or glossitis.
Okay.
And in the neck, I would like to examine this lymph node enlargement, especially the Wirtz node enlargement, because that if that's there, that means the lymphatic metastatic. And in the hand, I would like to measure the BP and pulse. And
So what are the things you're going to check in the abdominal examination?
On inspection, sir, as this patient already mentioned that he already had a cholecystectomy. I would like to check the surgical scar, and the chronic pancreatitis can lead to ascites. Because of that, I would like to check the patient having the abdomen is distended or not. And as this patient is a chronic alcoholic, that can lead to CLCD. Because of that, I would like to check whether the patient is having CLCD features like hepatomegaly, and also as this patient is having features of chronic pancreatitis, I would like to check whether there are any masses and tenderness of the epigastric area, and
suggestive of what?
Suggestive of pseudocyst.
Okay.
And and the
Right. Okay.
percussion.
Right. So as time is running, so we just move to the main discussion, right? Is that okay?
Okay,
Okay.
sir.
Let me share the screen. Right. I think with the just give me a second. Just can you see my screen? Can you see my screen?
No, sir.
So what about now?
Can see, sir.
Can see?
Yes, sir.
Okay. You can see my screen now, right?
Yes.
Okay. Right. So I think even though I had some interruption with the connection issue, so we had some conversation about the chronic pancreatitis history. When you come to the history, right? So okay. First, we'll discuss. So what I'm going to do is discuss about the history in the history taking, right? In chronic pancreatitis history. So it's I think you know that this is one of the complicated history you will get in for your final MBBS exam. Diagnosis of chronic pancreatitis can be achieved maybe 1 or 2 questions. So even though you think that you got the diagnosis of chronic pancreatitis, so you may not pass the exam. There are a lot of things to ask in the chronic pancreatitis history, and I think you asked most of the things. I mean, maybe for a reasonable amount you ask in your history, okay? And in the history, right? First, what is we need to know what are the things. First thing we need to identify is what are the problems of chronic pancreatitis. Okay, and in the problems, there are several problems. One main problem is pain. 90% of the patient with chronic pancreatitis, they usually have pain. Pain can be mild to very severe debilitating pain, like in this case. Okay, and when you consider the pain, you need to ask in and out about the patient, the pain. So when it start, how it has progressed over the time, and so what are the medication? Whether the patient is on any medication, whether the patient has had any kind of intervention for pain, those kind of things you need to ask in your history. And the other important thing is usually these most of the patient with chronic pancreatitis, they start with attack of acute pancreatitis. In the acute pancreatitis, the first So that means maybe 2-3 years ago, patient developed as this patient gotten pain. Okay, in the when you consider that thing, I mean pain. Right. You need to think about the pain. I mean, whether this is in between pain attack. I mean, whether there are any pain-free period is there or not. You need to recognize. And the other thing is whether this patient is having the background pain. On top of that, patient is getting episode of the worsening of pain. That means acute worsening over the period. And in that situation, you need to find out what are the causes for those the flare up of pain. So it can be getting the unusual prohibited, like the fatty meal, maybe getting another alcohol, even though you mentioned the things not to take the alcohol, or maybe any kind of complication developing, patient develop those kind of flare up of pain, right? And you need about the pain, you need to have full detail about the pain you need to ask, right? There are several causes for pain in patient with chronic pancreatitis. One of the most important causes is ductal hypertension. So ductal hypertension can be due to either pancreatic ductal stone or stricturing due to the disease process. Other thing is the ongoing inflammation of the pancreas. And the other one is increased parenchymal pressure. So with the time, patient develop because of the fibroinflammatory process. So patient develop fibrosis of the pancreas and causing the parenchymal pressure, increased parenchymal pressure. When it increased parenchymal pressure, it will cause the very deep visceral kind of pain. In case of ductal hypertension, that typical picture of the pancreatitis pain, the worsening epigastric pain, radiating to back, relieve with bending forward, those kind of things happen in ductal hypertension. And increased parenchymal pressure, deep visceral pain. So that is the reason to that thing. And neural inflammation and neuritis is the background kind of chronic pain. The other thing is with those things, patient develop central sensitization due to persistent nociceptive input. Right. The other reason for pain is complication related to the pancreatitis. Like suppose that patient develops pseudocyst secondary to the chronic pancreatitis. In that situation, patient the most pseudocysts are asymptomatic, but some pseudocysts can get pain because of various reasons, such as infection, pressure effects, bleeding into the cyst. Because of those kind of reasons, patient can develop pain because of the pseudocyst. Other thing is kind of biliary obstruction can lead to pain, or patient develop. We'll discuss those things later in the things. So those are the reasons for pain in chronic pancreatitis. We need to ask in and out about the pain and try to find out possible cause for pain during this presentation. Usually what we in the ward, when chronic pancreatitis patient comes to the ward, we just suppose that patient initially got alcohol and now patient is having chronic pancreatitis. But this time, even though patient has stopped alcohol for years, still patient can get pain because of the progressing nature of the inflammatory process. So, and other thing is, this particular situation, the pain can be due to complication. So complication can be lethal. Suppose that patient develop pseudoaneurysm and it rupture. and bleeding, a patient can die with that. So please remember that when patient present with pain, you need to just don't ignore that and giving some morphine and don't put those patient to the side, but you need to try to find out what is the reason. During the exam purpose also, you need to find out, try to find out what is the reason for worsening pain this time. When you consider the pain, so patient having so the pancreatitis is spectrum of disease. One end is acute pancreatitis, other end is chronic pancreatitis. So there are patients, acute pancreatitis and recurrent acute pancreatitis. There is an entity called recurrent acute pancreatitis. That means in between pain attack, patient is completely all right. Patient will get, usually what will happen is patient get first attack of the pancreatitis, and if patient, even though patient stop the alcohol or anything like that, sometimes develop the second attack, and gradually the time duration between the attacks get narrow down and continuous background pain, and then finally develop chronic pancreatitis. And with the chronic pancreatitis, background pain always there in extreme case. And the other thing is patient getting worsening pain in between. Okay, that is about the pain. So, so you need to ask in and about the pain in a patient with chronic pancreatitis. And other important thing is you need to you need to try to get a cause, a etiology for possible etiology for chronic pancreatitis. One thing is you should not forget to ask alcohol smoking in patient presenting with chronic pancreatitis. As I mentioned earlier, diagnosis is simple in the extreme end of chronic pancreatitis, but these are things. And the one thing is alcohol smoking. You should not forget to ask those things. And other thing is when you consider the etiology, toxins, autoimmune. So this is you do have the mnemonic called Tigaro. In Tigaro, you can get the etiology. So you try to remember those things. And even though idiopathic comes second, it should come at last, because you need to exclude, by exclusion of other things, you can get the idiopathic. So you should be able to find out possible etiology for chronic pancreatitis, like family history, any autoimmune condition, any previous history of severe pancreatitis attack, those kind of things you should not forget. And other thing is past history of abdominal trauma, so which also can lead to chronic pancreatitis later on. So that is about the etiology of chronic pancreatitis. And the other problems, the main thing is pain. The other problems are the functional. There are functional problems, structural problems, and risk of getting cancers, and psychological and social issues. Those are the main problems associated with pancreatitis. I'll describe those things. When you consider the functional things, exocrine insufficiency, in the history, she asked about the steatorrhea. So, but presence of steatorrhea means more than 90% of the gland is already gone. To appear the steatorrhea, so gland functional capabilities very minimal. Remaining functional capabilities very minimal. So in that case, you can get the steatorrhea. In early diseases, you may not get the steatorrhea. But in your history, you need to ask about the steatorrhea. So patient is not aware about the term steatorrhea, but you need to get the oily kind of stool, passing of oily, smelly stool, which is very difficult to flush. Those things you need to ask, but they usually don't develop diarrhea. But the oily stools will be there. So that is the exocrine insufficiency. And in addition to that, if that is there, you need to ask about whether patient is getting enzyme supplements, whether patient is getting enzyme supplements or not. Another thing is, if enzyme supplement is getting and still patient is developing steatorrhea, that may be some compliance problem. So in that case, you need to ask about how patient is getting the enzyme supplements. But usual enzyme supplement, common one is here is pancreatine, right? So usually they ask them to get the first with the meal, you get the first part of your meal, and then you need to get the pancreatine capsule, and that means with the meal you need to get that capsule. And about the endocrine insufficiency, the other problem is the endocrine insufficiency. You need to ask about the diabetes in a patient with chronic pancreatitis. When it comes to the diabetes, there may be patients who are having long-standing diabetes. You need to ask about the control of the diabetes. Recently, you got any difficulty in controlling the diabetes, even though you are strictly get the medication, or recent changes into the insulin, and or very early onset kind of patient got the diabetes. So recently patient got the diabetes or not, you need to get. And the other important thing is, they usually in the morning they're having 60s, and in the night sometimes they raise into 400, 500, like very fluctuating kind of blood sugar level will be there in a patient with so we call it brittle diabetes, or that means type 3C diabetes. You can get in chronic pancreatitis. Other problem associated with chronic pancreatitis is structural. So you need to think about the surroundings. There are arteries, veins, stomach, duodenum, those kind of things you need to think about. And the other thing is the disease process. They may develop pseudocyst. There are inflammatory mass forming. Another thing is fibrosis can occur in chronic pancreatitis. You need to think about this surrounding and the disease process. With that, you can get obstruction of gastric outlet. So it can be due to pseudocyst, or maybe due to fibrosis. You can get the duodenal obstruction. You can get, in case of gastric outlet obstruction, you can get, once you get the meal, after maybe after 1 hour, patient develop projectile vomiting. So that's how you need to get for the gastric outlet obstruction. Other important thing is bile duct obstruction. There are various ways to get bile duct obstruction in patient with chronic pancreatitis. One thing is pseudocyst. Other thing is the fibrosis can causing bile duct stricturing. Another thing is inflammatory mass compressing the bile duct. With those three reasons, patient can get bile duct obstruction. So if bile duct obstruction is there, patient will develop obstructive jaundice. So in patient with chronic pancreatitis, you should not forget to ask about the obstructive jaundice, and the supportive other three things, dark color urine, pale stools, and the itching. You should not forget to ask. And if that is there ever in the history, so you need to ask how do you get the treatment for that? That means what are the treatment you have had? So patient may come up with I had ERCP and stenting sometimes, or else you can ask whether you had any endoscopic kind of again happy singling camera එකක් දාලා මොන හරි ඇතුළට බටයක් දැම්මද කියන්නේ කැමරා එක දාද්දි so that is සිහි නැති කරලා තමයි දාන්නේ කියන්නේ sedation තමයි දාන්නේ sedation අපි upper GI එකයි වෙන් කරගන්නේ with the sedation you can ask that thing particularly if patient is not aware about the ERCP and there may be several previous episodes or may not be but you need to ask about the obstructive jaundice. Other thing is pancreatic duct also can block and worsening of pain can be due to that reason. In that situation, we can, when you discuss about the management, we'll discuss those things. Right. And the other thing, patient can get, there are surrounding veins. You know that behind the pancreas, you have the superior mesenteric vein joining with the splenic vein forming the portal vein. So that venous structures are there. So either all or maybe isolated, those veins thrombosis can occur. If superior mesenteric and portal vein thrombosis is there, patient develop esophageal varices. And when they get the esophageal varices, so they can develop upper GI bleeding. It may manifest as hematomesis or melena. And so if it is in the isolated splenic vein, so it can cause gastric varices, and gastric varices also can bleed and causing upper GI bleeding, again with the hematomesis or melena. So that is about the venous thrombosis. In addition to that, in case of portal, so whenever they get the venous thrombosis, it can causing portal hypertension. In case of portal hypertension, they can develop ascites. So there are reasons for ascites in patients with chronic pancreatitis. One reason is these things that increase that means the developing of the portal hypertension, right? And there are arterial structures. So it can so splenic artery, common hepatic artery, gastroduodenal arteries are in the vicinity and can cause pseudoaneurysm. Usually this pseudoaneurysm incorporate with the pseudocyst. Usually it's in the pseudocyst wall. So this pseudoaneurysm can rupture into the pseudocyst and causing HP dropping. So if it is contained within the cystine, so it can cause hemoglobin dropping. When you check the hemoglobin, it's dropped with compared to the previous. Another thing is if it rupture to the viscous organ like in the stomach or to the duodenum or to the jejunum, it can cause massive upper GI bleeding or melena. That means it manifests like maybe hematomesis or maybe with melena. Other thing is it also can those pseudocysts may be communicating with the pancreatic duct, so it can bleed into the pseudocyst and it emerge through the pancreatic duct. You call it hemosuckers pancreaticus. And other thing can happen is it can rupture into the peritoneal cavity itself and causing hemoperitoneum. And in patients who are collapse, patient coming with pain and patient collapse, developing tachycardia and hypotension, you need to suspect aneurysmal rupture. Another thing is there are various complications related with the pseudocyst. Those are overlapping with the previously mentioned things like the bile duct obstruction, gastric outlet obstruction. Other thing is you can get the infection mainly in case of infection. So when you come to the patient management of the pseudocyst, so it's basically the symptomatic, you need to do something. As long as it is asymptomatic, patient you can leave it alone. So it will gradually regress with time. And the other effect can get is the compressive effect, and you may develop early satiety, those kind of symptoms. Other structural change you can get is calcification of the calcification within the pancreatic duct, maybe in the main duct, or maybe in the branch duct, or else maybe in the parenchyma. If it is in the ductal system calcification, it can causing increase, as I mentioned earlier, increase intraductal pressure, ductal hypertension, and causing pain, worsening of the pain. And certain set of patient can, if patient live long period, patient can sometimes develop, there's a risk of developing pancreatic adenocarcinoma. So you need to suspect. I think she tried to ask that thing in the history. So you need to ask about whether patient is getting loss of appetite, long-standing, recent history of persisting loss of appetite, and anyway, patient is getting loss of weight and worsening of the pain, especially the back pain, may be indicated, maybe a reason for that may be developing adenocarcinoma. That means you need to suspect in those kind of patients adenocarcinoma of the pancreas. So in that case, you can do certain other tumor markers like CA 19.9, and if those are elevated, you can get the support for that diagnosis, and so that's an indication for surgery, the excision kind of surgery in chronic pancreatitis. Other main issue is you sometimes forget in your history is psychological and social issues. In this particular case, is a bus driver and it's unable to go to his job because of the severe debilitating pain. So there should be a lot of, and he is unable to enjoy any kind of meal or unable to attend to any party events, those kind of things he miss. So there are a lot of psychological issues which related to the chronic pancreatitis. Sometimes patients come up with suicidal ideas. You should be able to identify those things and mention in your history. Other thing is there are a lot of social issues related with that because it's because of the same reason, like losing job, those kind of things. Right. When you come to the so up to now, do you have any question? You can switch on your the microphone and you can ask any question if you have up to now. Malisha, do you have any question?
No, sir.
Anyone of you can even right. Just right. We'll see those things in our the Q&A session, right? Okay. Okay. Right. When you come to the investigation, so when chronic other important thing in the history is you need to ask about those the problems, and you need to get an idea about what has done up to now. Basically, in your history, when you analyze the pain and the things, so you have come up with those answers. If you miss anything, you can ask in the things what has done up to now. That means maybe CT, MRCP, ERCP. There are various kind of things. You can ask any surgical procedures, any intervention like celiac plexus blocking, those kind of things. I think when you analyze the pain, so it could have asked by now. Okay, and you should not forget to fill the rest of the component of your history, like allergies, past medical history, past surgical history, other than these things, other than which directly related with this chronic pancreatitis. and family history, social issues, not directly related with the history, right? Okay. And when you come to the investigation, you need to full blood count, CRP, liver profile. Definitely you need to do in this kind of patient liver profile to check whether liver functions are getting altered or not. And if they need to get you need to get the baseline renal function to go ahead with the future imaging. And amylase and lipase either normal or slightly elevated. If residual pancreatic function is there, amylase and lipase level will be elevated. So otherwise it's normal or low. Right. And lipid profile, calcium, those kind of things, basically it can for the cause for that thing. So whether this patient is having triglyceridemia, hypercalcemia, those kind of things. And HbA1c is to check whether the patient is diabetic or not. If patient is mentioned that I'm having diabetic, no need to do those things. But to get the control, how far it has control over the past months, you can get the HbA1c things. And suppose that if patient is having steatorrhea, no point of doing fecal elastase and fecal fat estimation. In case of normal looking stool, you can do this fecal elastase level. And there are value, if it is more than 200, it's normal consider. So 100, within 100 and 200, maybe it's mild kind of things. And if it is less than 100, so it can be affected. And other thing is, importantly, you need to have whatever the previous imaging has been done. If someone present again with worsening pain, you need to start imaging, right? Imaging maybe ultrasound scan, right? Starting with ultrasound scan. In the ultrasound scan, you can get a lot of information. Especially diagnosed patient with chronic pancreatitis. You know that this is chronic pancreatitis, but there are hundreds of ultrasound scan previously done, but still you need to have ultrasound scan. Why? So it is because you can see just not to see about the pancreas, but you can see the bile duct, those kind of the liver, what happened to those things. You can see whether it is duct dilatation, extrahepatic, intrahepatic duct dilatation are there. Those kind of things you can get, or whether there's any free fluid and obvious pseudocyst is there or not. Those kind of things are there, you can see. And so if you have any kind of doubt, you need to have the CCT. So when it comes to the initial presentation of chronic pancreatitis, I mean the early cause of disease, these investigations are mandatory. So CCT scan with if patient is there without having CCT, that can considered as negligence, medical length. So you need to have a CCT, even though patient is alcoholic or whatever the thing, you need to have CCT. In the CCT, there are certain features of chronic pancreatitis. So you can see the ductal system, basically the pancreatic duct. Whether there are any irregularities in pancreatic duct, ductal strictures, ductal stones. You need to check whether those are there or not. Other thing is, you can easily see whether pancreas is atrophied or not. In sometimes there are entity called focal pancreatitis. In that focal, whether there are the part of the pancreas is only affected. So you can see with the CCT those kind of things. And in addition to that, other thing like complication of chronic pancreatitis like pseudocyst, pseudoaneurysms, venous thrombosis, those kind of things can be seen in CCT. Right. If CCT is, this is MRI and MRCP is basically for if you have any doubt in your CCT with regard to the diagnosis of chronic pancreatitis. This is basically an early cause of disease, right? So you can see the changes, which can be seen in CCT, but in a bit early stage, you can see with the MRCP. Another important thing is pancreatic ductal anomalies like pancreatic divisum kind of things. You can see clearly with the MRCP. So in cause of chronic pancreatitis, at least one MRCP should be there to see whether there is any kind of anatomical problem is there or not, to check basically the pancreatic division. Right. In extreme cases, I mean, if you have very doubt about the diagnosis of chronic pancreatitis, basically these are in the early stage of chronic pancreatitis. So you may need to get the help of EUS, and you may get the EUS also. You can see the same changes, ductal changes, parenchymal changes in the very beginning of the course of disease. So you can see those things in the US, and if necessary, you can get the biopsies, FNAC or the biopsies to the US. And basically the US is, so that is for the diagnostic purposes, but for the management purposes, it is very useful, especially when it comes to managing the pancreatic pseudocyst. So you can put a stent, and so you call it Nagi stent. You can have EUS guided stenting. So that means cystogastrostomy. So that means putting a stent through the cyst to the stomach, through the stomach to the cyst. You can put a stent guided by the EUS. So EUS can be help in that situation as well. And other tests like IgG4 in case of if you are suspecting autoimmune pancreatitis, right? You can have the IgG4 levels. And other thing is we don't have these things like genetic testing. You can have in affordable patients. And as I mentioned earlier, if you are suspected to have converting it to a carcinoma, you can have CA19.9. Earlier, where the MRCP is not freely, not available, so ERCP was used to. ERCP was the test to see the ductal anatomy, but now it replaced by the MRCP. So now primarily it's used for the therapeutic purposes only. Right. Right. When it comes to treatment, right? So this may be complex and complicated, right? So suppose that this particular patient who is having whatever you did, patient is still in pain. So it may be complex and complicated. So you are out of options sometimes by the time patient present, right? Sometimes may need multidisciplinary approach, especially when you consider resection or drainage procedures. You need to always get the multidisciplinary. The other thing is whether it is patient transforming to a cancer. In those kind of situation, to get doing the resection, those kind of things, you need to have the multidisciplinary approach. Sometimes when you are managing the pain, right, you may need to get the help of the anesthetist sometimes to do the things. So the multidisciplinary approach in some patient, you need to have that thing. And other thing is get rid of the pain. So main problem with chronic pancreatitis is pain. So you need to get rid of the pain. For pain, to control the pain, so in 90% of the patient with chronic pancreatitis will have pain, right? In only 10% will not have pain. So they usually detect during the cross-sectional imaging. So you may get the diagnosis of chronic pancreatitis, or may be present with suppose that patient develops steatorrhea. So when you investigate, patient is having chronic pancreatitis. So that is only 10% of the patient. But 90% of the patient is having 90% patient is having pain. Right. When you manage the pain, you should identify the reason why patient develop pain. So to get the help for that, you need to see this slide again. And in case of ductal, right, first thing is before the intervention, you can manage starting with medication, like starting simply with maybe paracetamol, Panadine. Try to avoid NSAIDs because it can aggravate the, peptic ulcer disease and renal problems it can causing the NSAIDs when you use it longer period. And you can add tramadol and maybe on the oral morphine or neuromodulators. You can add like gabapentin, pregabalin, those kind of things for the treatment. So you can get the pain physician, so the anesthetist for these kind of things to adjust the pain medication. And there are interventions like minimal invasive interventions. And when you consider the minimal invasive interventions, one commonly used thing is ERCP. And ERCP, in all the patients with pancreatitis, we can't do the ERCP. Okay, the ERCP helps in patients who are having ductal hypertension. Ductal hypertension, because of the stricture or stone, so it evident in CT with dilated pancreatic duct. That's why we need to have the imaging studies to see whether there are any treatable things are there or not. So in that situation, you can, in patient with ductal hypertension, you can initially go ahead with the ERCP and stenting. You can put a plastic stent, and with that, if patient get rid of the pain later on, so you can keep on changing stent, or else you can go ahead with the if patient is fit enough and patient is agrees to go ahead with that, you can do the drainage procedures. So that is surgical options. And other thing is, suppose that if there is a stone in the main pancreatic duct, right? So in that situation, you put the ERCP and you can send this patient for ESWL. And with the ESWL, you can fragment the stone and you can get gradually take it out the stones. So suppose that you do the ERCP and there is a big stone, you should not try to take out the stone there. So it can damage the pancreatic duct and can cause more harm to the patient. So what we do is you do the ERCP and put a plastic stent and send for the ESWL. If you can get that thing, and once it break the stone with the subsequent ERCPs, we can take out the stone particles with that. And the other thing is for the ongoing inflammation, actually with the medication you can manage. And other thing is, suppose that fibrosis of parenchyma. Suppose that there are localized areas. So if that is the inflammatory mass and fibrosis, they are in the distal part of the pancreas. So you can do the distal pancreatectomy. So you need to be very careful when you consider to get the Whipple's procedure for that thing. In case of head and neck of the part of the pancreas is involved, you can do the Whipple's, but it's the multidisciplinary. We need to go to the multidisciplinary team meeting and then need to decide after having a discussion with several people. And another thing is the other cause for the pain is neural inflammation and neuritis. So in that case, so you can have the nerve ablation things. So if the medication fails, you can have the nerve ablation like celiac plexus ablation, like you can have the alcohol ablation. So you can get the radiologist or the anesthetist help to ablate the celiac axis. And other thing is you can have the surgical option also there. You can have bilateral thoracoscopic splanchnicectomy. So you can divide the splanchnic nerve by doing the thoracoscopy. So that also work well in patient with if they are having neural inflammation and neuritis. Right. So when patient comes to central sensitization due to persistent nociceptive, so whatever the mean you do, it might not work. So whatever the procedure done, it might not work. So that's how things happen. And other thing is complication also can causing complication related with the chronic pancreatitis also can causing pain. So in that situation, so you need to manage the symptomatic pseudocyst, as I mentioned earlier, biliary obstruction maybe with the ERCP or sometimes maybe with the operative procedures like you can have a Roux-en-Y hepaticojejunostomy, etc. And if someone is developing aneurysm, you can always get the opinion of the interventional radiologist and you can embolize that thing. Like that, complication you can, the pain because of the complication you can manage. Right. So that's about the get rid of the pain. So when it comes to the intervention, there are the surgical intervention. It's as I mentioned earlier, there are drainage procedures like phrase procedure, Begas, like there are various kind of drainage procedures. I don't think you need to remember those names. And there are resection procedures. Resection mean distal pancreatectomy, Whipple's maybe sometimes the total pancreatectomy. And other thing is there are combined procedures like head resection and like pancreaticojejunostomy, like those kind of procedures you can do. You just remember that you need to have, there are drainage procedures and the excision procedures for the chronic pancreatitis. And other important point is reduce disease progression, right? So reduce disease progression mean you try to find out a reason for chronic pancreatitis. That means the etiology. So if patient is alcoholic, you need to stop the alcohol. Ask the patient to stop the alcohol. If patient is addicted, you can get the help of others to stop the alcohol like that. And alcohol and smoking. Definitely you should, you need to ask to stop those things, otherwise it will progress. And another thing is, you need to find out cause. So if someone present with early in the course of the pancreatitis, finding out the cause is very crucial. I mean, so you need to have the basic, those blood investigation to find out, I mean, like triglyceride, the ultrasound scan, you can have the gallstone. So with the gallstone, directly they won't do the chronic pancreatitis. Suppose that patient develop severe acute pancreatitis and later on patient can develop like that. Or if you miss with the acute pancreatitis attack, you miss the gallstone, the second attack may be again because of the gallstone. Like that, rarely you can get those patients who are having gallstone, but unfortunately haven't done the cholecystectomy. So in that case, you need to take that thing out. And other thing is, you need to find out if hypertriglyceridemia is there. You can easily treat those kind of things. Hypercalcemia secondary to the hyperparathyroidism, you can free, right? So those kind of things, there are certain things to reduce the disease progression. That means you need to try to get rid of the etiology. So the other thing is, suppose that patient is having some autoimmune kind of pancreatitis. So IgG4 level, you can get the IgG4 level, and if that is there, treatment with the steroid, you can reduce the disease progression if that is the cause. That's why we need to do the things. And CT also, you can get the sausage shaped pancreas in case of that means when you get the cross-sectional imaging, so it's usually the triangular shape, but here in the this autoimmune pancreatitis is round, so you can get that thing. If that is there, even with the CT, you can consider the cause of steroid for those patients. So somehow you need to try to reduce the disease progression. That's also part of the management. And other important thing is, when patient I mentioned it earlier, when patient frequently visit the hospital because of the pain, each and every time you look for the reason, whether there is any change, I mean, whether there is any complication patient is developing. So this worsening pain can be due to a complication. So identifying the complication and treating that thing is also a part of your treatment. As I mentioned earlier, pseudocyst, pseudoaneurysm, those kind of things you need to treat. Another important thing is psychological and social support. You can get the help of relevant people to for those things like counselors, psychiatrists, those kind of people, and social workers to get the help for those patients. Right. I think I have covered the chronic pancreatitis things. There are a lot of things to discuss, but if you have any question, I can answer. Right. The question number 1, sir, don't we have to exclude inferior MI as well? So in this situation, you may ask, but this is straightforward chronic pancreatitis. Though excluding the differential diagnosis is not the problem. I mean, that is not the target. So you need to, as I mentioned earlier, you need to find out what are the problems currently patient is having. So in chronic pancreatitis is not the difficult diagnosis. You can get the diagnosis very easily, but the problem is the things you need to ask about the complications, those kind of things in your history. So that is not mandatory. I mean, so in case of acute pancreatitis, yes. So this is MCQ. 45-year-old chronic alcoholic presents with recurrent abdominal pain, steatorrhea, weight loss, presents and a mild fever. What is the best test to identify the cause of the presentation? So I think this is an incomplete question. So when it comes to your MCQs, I think you need to you should not try to find out answers of those suboptimal MCQs, which is usually prepared by your seniors with the final exams. They remember the things and write it here. A lot of statement can be missed. So what you need to do is you need to read around the question and get the answer. I think so these things. Okay. Do we do ERCP stone removal for diagnosed acute gallstones pancreatitis? What is the window period for it? Right. This is actually related to the acute pancreatitis. If someone presented, so that is the indication for ERCP in a patient with acute pancreatitis. Right. acute pancreatitis associated with cholangitis. So you need to have the ERCP and stenting. So this is need to discuss in acute pancreatitis. There will be a sir. How long will it take to develop adenocarcinoma of pancreas as a complication? So I don't know exactly the time period, but should be longer than maybe 10 years. I think longer the course of pancreatitis, so they can get the chance. So in maybe in 2-3 years, it's a bit unlikely. What are the important things to be covered during the examination? So yes, in the examination, as you mentioned, you need to look for PALO, nutritional deficiencies like angular stomatitis, glossitis, jaundice, right? And in case of if a patient is having a longer history getting the lymph node, right, and bilateral ankle edema, those kind of things. General examination and patient's BMI, height and the weight, it will be provided in your exam. And when it comes to the abdominal examination, try to find out a pseudocyst, ascites, hepatomegaly, splenomegaly, those kind of things, and previous surgical scars suggestive of certain procedures, those kind of things. Right. So again, MCQ, I think 50 all patient with history of chronic pancreatitis and diabetes mellitus presented with exacerbation following a bout of alcohol. Imaging revealed dilated pancreatic duct and 6 centimeter pancreatic pseudocyst. What is the best method of acute pain management? So here there is a pancreatic duct dilatation. So in that case, pancreatic duct stenting, I would consider the pancreatic duct stenting first, as this patient is having the pancreatic ductal hypertension, even though the size of the pseudocyst is 6 centimeter. So first I will try with that thing, and if still pain is there, so we can think about the pain because of the pseudocyst. What is the cause for this case for chronic? What is the cause for this case for chronic pancreatitis? Patient is, in this particular case, should be the alcohol. That is a common thing. So when it comes to alcohol, so every patient who are getting alcohol or not getting, I think there were maybe 10% of patients who are getting alcohol develop chronic pancreatitis. So even though patient is getting lot of alcohol, so alcoholics, right, you need to find out other causes as well, right? So you need to find out other causes, like you need to do the full set of investigation to rule out other things. And in the meantime, you need to strictly advise on stopping alcohol and smoking. So if that is there, still patient getting the chronic pancreatitis, still, so there is a thing called sentinel acute pancreatitis event, right? So in that case, sentinel acute pancreatitis event, that means with the first pancreatitis attack, so it will start cascade of event to start the fibro-inflammatory process, right? So in that situation, so you need to reduce the causative factors for the acute pancreatitis. Even though you stopping that thing, in some susceptible patients, it can progress even though you stop the alcohol. If you continue alcohol, so it will ended up with disaster. Okay. Regarding last MCQ asked, acute management, so can't be answer A. Right. Usually here, so they didn't specifically ask about what is the immediate management, right? So that's why. So we need to have a clear-cut, full question and the answers. So otherwise, it's very difficult to answer the MCQs, right? So don't worry, when it comes to exams, if you know the subject matter well, right, you can answer more than 95% of the MCQs. Don't worry about that. So because those are very clear, scrutinized questions and the answers. Dr. Dixon and Abhay Singh sir will agree with me. So we are having a lot of discussion when we preparing the MCQs. What is the cause for this? Right, okay. So can pancreatic CA cause chronic pancreatitis? Right. The other thing is there are patients who are having not exactly the cancer. Cancer won't progress until patient develop the chronic pancreatitis. But because of the cancers, patient can develop acute pancreatitis. Suppose that patient is having an obstructing lesion, maybe a precancerous lesion like IPM and MC and those kind of, there are various kind of cystic neoplasms are there. Those are pre-malignant. That means it can someday, it can change into the pancreatic adenocarcinoma. In those situations, patient may get the pancreatic, pancreatic neoplasm, not exactly the CA, can cause the chronic pancreatitis. So that's why we need to have the full set of investigation. So in first go, we can identify those things with the CCT and the MRCP. Right. What is the gold standard method to diagnose chronic pancreatitis? When the diagnosis of chronic pancreatitis, I think I mentioned it earlier, when it comes to the early stage of the disease, so it's very, very difficult to diagnose the chronic pancreatitis. You may have seen the patient who are having, treating several years for gastritis. Later on, when you check, patient may have developed the chronic pancreatitis. So identify the diagnosis in early stage is very difficult. So diagnosis is the gold standard should be in that situation should be EUS guided biopsy. So somehow you need to get the tissue biopsy. So if in the tissues there are chronic inflammatory changes, you can diagnose in early situation. But when it comes to late stage of the chronic pancreatitis, it's quite different. So even with the X-rays, sometimes you can diagnose the chronic pancreatitis. So chronic diffuse kind of calcification across your upper part of the abdomen. So that may be the diagnosis of chronic pancreatitis. But there, the standard investigation is CCT, pancreatic protocol, in which you can get the diagnosis and the whether ducts are dilated, whether stones are there, those kind of things you can check, and any other complications are there or not, you can check. Right, I think I have answered all the question. If you have any other question, you can ask.
I think this is for all the participants. I think this is a good time to ask questions because rather than just go home and discuss among yourself. So in the absence of questions, shall we wind up the session?
Okay.
Dr. Anuradha, actually, it's it's a very fruitful discussion. I'll be very thankful to you on behalf of Wayamba Medical Faculty as well as Rajarata faculty, though I am not working here. And you have taken a lot of effort to organize the thing. And thank you very much, Dr. Anuradha. And I think students will take maximum benefit out of this discussion. Thank you once again.
Okay, thank you, sir. Thank you very much for the opportunity. Good night.
Good night.